Today, we're going to try and answer a really interesting question, which is, can a blood test screen for cancer? Now, what we're going to do is we're going to talk about a really quite exciting development in the realm of medicine, which is various blood tests that claim to be able to essentially screen for a variety of cancers and pick them up very early. So cancer treatments are evolving really fast. And in our previous episode with oncologist Dr. Harry Gasper, we discussed the developments in novel cancer care. But as we know, cancer treatment has a far greater chance of success if cancers are identified early. So rather than waiting for symptoms to develop, what if we could identify those likely to develop cancer before they've experienced any symptoms at all? We're going to be talking about a test that developers claim might be able to do just that. Now, I want to read to you, Matt, a claim off one of these companies' websites, which says, with a single blood test, this test can detect signals from 70 types of cancer. From another company, this is a multi-cancer early detection test, a test that can screen many of the deadliest cancers before they become symptomatic, including those with no recommended screening tests today. So what does this entail? Can anyone have the test? And how accurate are they? And what does a positive result really mean?
Yeah, I think this is a fascinating topic, isn't it? We've got so many tests at our disposal now as doctors. But the idea of having quite a neat test, like just a blood test that can diagnose early stages of cancer, that really does sound enticing, doesn't it? I think we need to lift the hood and look underneath at the critical details of this a bit further, though, don't we? So that we understand it better and that our listeners can understand whether or not it's worth purchasing one of these tests, because at the moment they are only for private paying patients, aren't they?
Absolutely. And the devil is in the detail for this. So I think it might be helpful to talk a little bit about cancer screening. And I know, Matt, you're going to summarize for us a little bit about cancer rates, because the cancer rates are not anything to be proud of in the UK. I believe in comparison to other countries, they're actually pretty shocking.
Yeah, I'll give you some stats now. I don't need to dwell on this too much to labour the point, because I think everyone understands the scale of cancer and how devastating it is. But just to give you some quick stats, cancer in the UK is diagnosed at least every 90 seconds. 1 in 2 people in the UK will be diagnosed with cancer in their lifetimes. An average of 460 people die every day in the UK from cancer. Now, there's also some quite kind of, I'd say, worrying trends around this as well, because looking back, say, from 2009 to 2019, the rates of cancer diagnosis have also gone up by 20%. Now, the counter-argument to that is, of course, that we've got an ageing population, we're getting better tests at diagnosing cancer and public initiatives and screening. But I think it's shocking that the rates, it's quite startling that the rates of cancer actually are going up over that decade. Now, zooming in a little bit on the specifics of cancer, there are the big four. There's breast cancer. This is the most common type of cancer among women in the UK, with 59,000 new cases that are present in 2021. Second most common is prostate cancer, with 51,000 cases diagnosed in the same year. Number 3, we've got bowel cancer. And again, this is quite alarming because we're seeing that the rates of young people getting bowel cancer are going up. And I think if anyone wants to learn a bit more about that, like you said, they can look back to our episode with Dr. Harry Gasper. And then number 4 is lung cancer. This is the 4th most common type of cancer in the UK, with 48,000 new cases diagnosed in 2021. Now, in the NHS, there are screening programmes, and I'll just outline a little bit what's available at the moment and why, because I think it raises quite an interesting point here. That at the moment we are screening for breast cancer, cervical cancer, bowel cancer, and most recently you can now get screening for lung cancer. For breast cancer, this is particularly relevant for anyone between the ages of 50 and 70. For cervical cancer, this is now aimed at those women between 25 and 64, with the aim that hopefully we can actually eradicate cervical cancer with the development of these new vaccines. We also have bowel cancer, and anyone who's between 50 and 74 is eligible for a bowel cancer screening test every 2 years. And then most recently, we've now got this lung cancer screening, which is being offered in the UK to people between the ages of 55 and 74 if you've ever smoked. The interesting thing about all 4 of these screening methods is that none of these involve a blood test. For breast screening, this is an X-ray or an ultrasound. For cervical screening, this is a smear test. This is sampling of the cervical cells directly. In bowel cancer, this is a stool test, so looking for blood in your stool. And in the lung cancer screening, this is the use of CT imaging of the chest. There are blood tests available, and I'm sure our most avid listeners will remember our episode on prostate-specific antigen testing. I think that might have been our 2nd episode. Please do go back and have a listen. there are blood tests that are available that can be helpful in detecting cancers. But the important thing here is that none of these blood tests are actually used as screening methods to date. So I've mentioned already a blood test for a prostate-specific marker. There are other markers looking for ovarian tumour markers, pancreatic tumour markers, etc. But these have been studied and reviewed, and it's been decided that actually they're not suitable for screening purposes. They're a useful adjunct in diagnosing cancer, but they're not used for screening. Now, that brings me on neatly to outline that, yes, we are talking about a blood test here, aren't we? Enter this new blood test that is offering essentially the detection of 70 plus types of cancer simply in the blood test. Do you want to tell us a bit about these blood tests, Mike, and how they might work?
Yeah, totally. So we're essentially two companies or two tests that I want to focus on that we'll talk about how they work, because these are more relevant for us. So the first one is a test called Trucheck. Now, this is a test that essentially looks for something called CTCs. So that's your circulating tumour cells, or the slightly longer acronym, which is CETACs, your circulating ensembles of tumour-associated cells. Again, you can see why it's an acronym, in a peripheral blood sample. So the way this works, and just to get very technical just for a moment, so the sample undergoes what's known as primary negative enrichment. It allows non-malignant cells to essentially die by their functioning apoptosis methods. Now, malignant cells are able to survive. They can then look at tissue organ-specific markers on the cells to identify those expressed in the cancer cells across multiple types of something called multiplex fluorescence immunocytochemistry. That's not the first time I've had to practice that. The other test to mention briefly is called Gallery. Now, Gallery currently isn't available in the UK. However, Gallery is undergoing quite an extensive trial via the NHS to assess its efficacy. So watch this space in terms of that. There may be some interesting developments in that. So who can have these tests? So it's not for everyone. You have to be over 40 years of age or between the ages of 35 and 39 if you've got certain risk factors there. Family history of cancer, known to be a carrier status. So some of you will be familiar with the BRCA gene, the BRCA mutation, obesity. So if your BMI is over 30, you've got type 2 diabetes, you've got a history of infectious diseases, hepatitis, HPV, this kind of thing. And there are various other criteria as well. So the headline here is that there's a blood test to test for cancer. We need to be very careful with that because, again, the devil is in the detail. So the presence of these CTCs, so these circulating tumour cells, is not diagnostic of cancer. So if you do this test and you get a positive result, it essentially means the person is at high risk of cancer. Now, the result can usually explain or reveal what type of cancer this is and the likely organ of origin, but that's not always the case. It's also worth just pointing out that you can't have this test if you currently have cancer or if you have symptoms that a very high risk of cancer that needs your urgent 2-week referral to go and get that checked out as a matter of haste.
Interesting. I don't know if you found this, Mike, but looking online, I've realised that this costs about £1,200 to £1,300 for this test, and I found that it's a blood draw. So this isn't a thimble, a thumb prick of blood. This is a number of vials they draw. I think I read 25 mils. So that's probably about 10 of the standard blood tubes that you would normally have for a blood test. I'm going to move us on to how accurate are these tests, and to do that, I'm going to take us on a brief trip back to medical school to grapple with this notion of sensitivity and specificity. And I'll try and make this as clear as I possibly can, because I think these are two metrics that are important when you're evaluating the use of a new test. So, sensitivity is the proportion of people with the disease who correctly test positive. I guess drilling into that a bit more, highly sensitive test is important when it's crucial to detect the disease and avoid missing any cases, such as for a widespread and serious illness like coronavirus or something. You want to be able to find the disease. So having a highly sensitive test is useful in that respect. Specificity. Now, this is the proportion of people without the disease who correctly test negative. And again, drilling into that a bit further, this is an example of a highly specific test. This is valuable when you want to ensure that only the people with the condition are identified to avoid any unnecessary further investigation or treatment for those who are actually healthy. And I think that's really important to kind of bear that in mind when we look at these stats for these blood tests.
I swear I must read about sensitivity and specificity pretty much every day in my working life, and I still have to pause and think about what it means. But sensitivity is avoiding your false negatives, whereas specificity is avoiding your false positives. Have I got that right?
Yes, well done. Well done.
Thank you.
And hopefully, did I actually manage to explain that in a kind of fairly coherent sense? I don't know. Our listeners can tell us. Please leave kind comments. Now, I've got these. These are the actual stats taken from the Datar website. So Datar is the maker of Trucheck. It looks like they've got a live section that's updated with new trials, and they amend their statistics according to the latest studies that have been done. So I think that's quite impressive as a first point. On the website, it says, in clinical studies, Trucheck has a sensitivity of 88% in the detection of cancer at all stages and types. That sounds pretty good. Pretty good, I think. It's not bad, is it? 88%. So that is when someone has a cancer, this test misses the fact that they have cancer 12% of the time. So it is helpful in diagnosis most of the time for those who have cancer, but it is also missing a fair number of patients who actually have cancer. The real world data, however, so this is the real world studies that have been done, shows a sensitivity, depending on the tumour, somewhere between 65 and 89%. So that's a bit worse. So clinical studies, 88%, but in real world data, they're seeing that actually the sensitivity is around 65 to 89%, depending on which tumour we're talking about. And of course, it's screening for 70 plus types. It also says that in the real world data, it has a specificity of between 96 and 99%. Now, this is a much more impressive statistic, but actually this is the bit that troubles me, because a specificity of 96%, that means that 4% of the positive diagnoses that you outlined, Mike, these are false positives. So this is a cancer test telling up to 4% of patients who have it done that they have a cancer when actually they don't.
Yeah, definitely. Right? And I think, no, that's absolutely right. And I think that's an important point to make, because I think when you hear 96% for anything, you think that's pretty good. That's great. But actually, when you look at it the other way and you think 4 in every 100 people who have this test are potentially going to get a false positive, that frames it in a slightly different light, I guess. Now, moving a little bit on to, again, the detail, talking about the evidence behind this. So does the evidence back up the claims that are being made? And I think that when we look at this, we're talking about the company here that make Trucheck. They've published papers in scientific journals, reputable scientific journals, in fact, The Lancet, in the Cancer Journal, essentially to validate the test's technology. These studies report on how good this test is at detecting cancer and its accuracy in predicting exactly what organ that cancer is coming from. It is worth pointing out, though, that the available data that they have does appear to be limited to a single conference abstract, and that's reporting analytical and clinical validation in a cohort of just under 600 participants. So it's got really promising sensitivity and specificity figures in those retrospective and prospective cohorts, but those results have not been published in a peer-reviewed journal, and the study design, the sample size, and that lack of external validation, it's felt to kind of limit the strength of the evidence here, really. So I think it's interesting, actually, because I was asking myself the question, in that as a company, why are they not doing bigger tests, or why are they not doing further tests? And actually, if we look at this in terms of why you would do the test, so you do the test and you get results that allow you to market your product, that's kind of all they need to achieve. There's no benefit, really, I think, from a lot of these companies doing really extensive tests, because they don't need to. Best case scenario, it's going to show what they're already showing. They've already got the license for it. Worst case, it disproves their original figures. So it's an interesting one to think about. We did talk about the Gallery test as well. Now, really interesting, that study that's happening in conjunction with the NHS. So as of September 2025, when we're recording this, we don't have the results for that. Now, that may change, and this may move the goalposts a little bit more.
Can I just say on that, though, they have published some statements about it saying that it's too early to say. But what was slightly damning is that they have, back in, I think it was 2024, they were originally planning on doing an initial study and then rapidly expanding this study to a much bigger scale study if the initial results showed promise. And their statements kind of said in somewhat ambiguous terms that the initial results haven't been as promising as they were hoping for. So they're just waiting on the extended results from the first smaller scale. I think like you said, we're expecting those to be published in 2026.
Yeah, absolutely. So watch this space very much. I wanted to talk a little bit about the limitations of this. So these are limitations that the company completely accepts themselves. So again, it's important to focus on these if you're thinking about having this test. So this test is very much a complementary test, not a replacement. So it doesn't replace standard of care screenings such as mammograms or colonoscopies as you described. And it's absolutely not a replacement for them. It's a complementary service. Now, it focuses on these CTCs, so these circulating tumor cells, and that means it may miss cancers that don't shed these cells into the bloodstream as readily. So we're talking about things like blood cancers, and so cancers like leukemia, lymphoma, multiple myeloma. They're not solid tumors, so you're not getting any shedding, so they're not going to pick up any of these. There are also certain solid tumors that shedding rates kind of vary. So they actually shed very few or no detectable CDCs, especially in the early stages. So these are things like your brain tumors, some really early stage cancers. So there are limitations to the test. The feeling is actually that the most validated cancers for which this is useful are breast cancer, prostate cancer, colorectal cancer, and lung cancer, which are the big top four, which you outlined, which we have screening for already. So make of that what you will. I mean, I think it's very much being framed as an adjunct, as a complementary service, rather than, as I said, replacing anything at all.
Yeah, really good points. That's interesting. I didn't know that it was most helpful in picking up the big four that we outlined at the top. I did read also in that some of the trials involved with the Gallery test that they are finding that it's not as promising when just used in asymptomatic patients, like you said, in isolation, just as a test in its own right. But they're finding that actually used in, like you said, to complement other screening methods. So one example or one trial that was quite helpful was that if a doctor has a suspicion of an upper gut cancer, an upper GI cancer, often the scans that we request for this are normal because the tumour can hide inside the stomach and it's not easily visible on the scans. But when a patient is having vague symptoms, apparently this test is actually quite helpful in directing investigation. It can give the doctor a bit more of a clue as to where to look. So I think there might be some really, really helpful pockets. But of course, like we've said, the main data or the main results from this study are coming out in 2026.
The other question that I wanted to know when I was thinking about this was whether if you have a test that shows these CTCs in the bloodstream, does that automatically mean a person has a growing life-threatening tumour? Are they going to develop cancer? Or can you get a positive test that is accurate, but actually is of little relevance, and if you never knew, it wouldn't have developed? And it's a difficult question. I think from what I could find, there are situations where you can get CTCs in the bloodstream in a kind of benign way, for want of a better word. So you can get some dormant CTCs. So I think research has shown some evidence of these that have survived the journey to a distant site, but would essentially remain inactive for years or even decades. They may never develop into a full-blown tumor. You can apparently also get shedding in healthy individuals. So some studies have reported finding cells with characteristics similar to CTCs in healthy individuals with no evidence of cancer. So just worth bearing that in mind as well, I think. Now, I think a really big topic that we need to talk about when it comes to these tests is the ethical considerations, because there are many of these.
Yeah, I think you're right. This is the meat of the conversation here, isn't it? I think with these tests, this sounds very promising. This idea of a liquid biopsy, just a blood test. But you've mentioned quite a few times the devil being in the detail, and I think exploring the ethics behind these tests, it might help people understand the complexity and the nuance to actually deciding whether or not this is helpful or not. So coming back to our specificity and sensitivity, you mentioned nicely about this idea of false positives, and I guess the psychological harm that could be caused by a false positive. So we mentioned again specificity ranging from 96 to 99%. depending on which tumor types you're looking at. But can you imagine the psychological impact of being told you have a cancer when you actually don't? So that for me is that's quite a big sticking point.
And I think I would add to that in terms of looking at it from the other side. So if you get a negative test, and are you going to be falsely reassured? And therefore, if symptoms do develop in the coming months or years, there could be a situation where someone looks at it and think, well, I did that test and it was fine. It was negative. I don't need to go to that screening appointment because I've had that blood test that showed everything was fine. So there's that side of things as well.
Absolutely. And again, going back to the false positives, the idea of being given a false positive, that the ensuing harm from that is not just psychological. There is additional imaging, invasive procedures, actually even biopsies and things, just to trying to find this tumour that might come from that.
And also, just on that, say you have private medical insurance and you pay and go and have this test done and it comes back as positive, it's not a given that insurance companies will pay for any further treatment or investigation. There is a situation where you could be left in this scenario where you have a positive test and all of the anxiety that ensues with that, and then you're in a almost impossible situation where you're trying to decide whether to shed out huge amounts of money for further investigations, which you're not entirely sure whether you need right now or whether you can monitor things. And I think in the wrong hands, I think this is potentially quite dangerous. The other thing to mention is life insurance policies. These kind of things are kind of adjacent to medicine, but are important. So, if you've got a life insurance policy and you're having to declare that you've had this test, what's the significance of that? Is that going to shoot up your premiums? I don't think we have an answer, or I don't have an answer for that, but it was certainly a consideration.
Yeah, it's a really good point. And particularly for, like you said, if there's this dormant cells or this dormant shedding that's detectable on a blood test, but then you can't actually find the tumour for several years or if not decades, how do you then ensure someone going forward with a known potential risk of developing cancer at some point? It's a bit of Pandora's box, isn't it?
It probably is worth mentioning, just for balance, that believe that the Data Cancer Genetics company, so the company that makes Trucheck, will contribute up to £1,000 for follow-up diagnostic tests that have been recommended by a doctor following a positive result. So that's positive. It does make me wonder whether there really are limitations in terms of getting access to further investigations and scans, given that they're offering a financial reward.
Another ethical consideration that we have to touch on here is about this idea of informed consent and the communication challenges that I guess we're trying to summarise in this podcast here, but are clearly quite complex, aren't they? And explaining to a patient who's considering one of these tests the potential implications that might follow on from this. I think it probably takes extra training, specific skill, certainly a medical degree, to be able to explain some of this, but it's all quite new to us and I think is fraught with complexity. I read an interesting piece from an oncologist called Dr. Cornes, sorry if I'm mispronouncing your name, but he made some really good points in a BBC article about the trouble with finding these circulating tumour cells. Is that what if on the blood test you've detected it, but like we've said, the tumour is too small that you can't see it. So you cannot then radiologically find it or diagnose it. And we don't know how long this process will last. Could this be for days, weeks, months, or even decades until actually you're able to detect a tumour that could harm you? Is knowing that you might get cancer when you're 120, he says, is that helpful when you're in your 50s? It raises an interesting point, doesn't it? In this same article, he also made another point saying that he looked at the data presented by Data Cancer Genetics. And one of their studies was done in India, and it looked at 16,000 people. And he noted that out of every 1,000 people tested, 44 in the trial would be testing positive for circulating cancer cells in their blood. And within 1 year, only one will have a cancer diagnosis of a solid tumour. We're then left with, 43 people out of 1,000 being told they have a positive blood test, but no actual formal diagnosis after that.
So I wanted to ask you, Matt, in terms of what we've discussed and in terms of what you've read, what are your views on this? Is this something that you feel positive about, or do the limitations of it and the ethical considerations that we've discussed, do they outweigh this at the moment?
Yeah, I think on reflection, I've probably come across quite negative here. I think I've been trying to pick holes in these tests, but overall, I think this is great. I think this is hugely positive, and I want to encourage further research in this. And the idea of having more simple ways of detecting cancer is obviously that's a good thing. I think the idea of detecting cancer at an earlier stage, so before having symptoms is certainly ideal and is of benefit. But I think, as we've outlined, there is huge complexity into the ethical considerations and also how this is communicated with your patient. I mean, for some, knowing that they are likely to develop a cancer in the next few years and that it may be caught at an earlier stage is worth the money, worth the anxiety, worth the rounds of further investigation required. But I think for some, that news may be crippling and psychologically even destroying for a cancer that wasn't even going to harm them or limit them physically. So again, I guess that's person specific. I was just wondering, kind of, how often is one supposed to spend £1,200 on this test? Is this something that we should be getting done annually, or?
I think that's the suggestion, that it should be an annual test, ideally.
So, Mike, what are your key takes here?
For absolute transparency, and it's probably worth just for to make it clear, is that one of the surgeries that I work at offers this as a test privately. But I think I can hand on heart express my view on it, and it is that broadly this is really positive. So look, I think we touched upon it at the start, but the UK, we're talking primarily about the UK where we both live and practice, has got terrible cancer rates. So we're lagging behind Europe in terms of identifying cancer, in terms of survival rates. So anything that can ameliorate that, can add to that, has got to be a positive. Now, there absolutely are limitations. I have reservations, particularly with in the wrong hands. If this test is being offered online with no follow-up and no counselling and no explanation as to the implications of it, then I think that's where we're going to run into serious problems here. And patients are going to present to their NHS GP with these results, and they may not be able to be referred because they haven't got symptoms. So there are situations where this could be disastrous. But I think in the right hands, and people going into these things with their eyes open, they understand the limitations of it. They understand the implications of a positive result, whether that be the insurance purposes or their own mental well-being and the physical tests that might entail. I think it's a tool that can complement the current screening tests that we have. And actually, if this technology develops still further, there are more tests done. I suspect this is not where this technology ends. Then I think looking in the future, it could be hugely exciting, because this is, as we've touched upon, this is what everybody has been looking for, are these tests. I think it's fair to say it's probably too early to say 100% whether it's going to be an absolute game changer, but I am quite excited about it generally.
Now, Mike, I'm going to spring something on you that I don't think you've prepared for. But given what we've talked about, given the complexity, the uncertainty, and the need for further studies here, is this something that you would have done? Is this something you would pay for to have done?
Are you providing me with any financial contributions?
No. You've got to pay for it out. You've got to pay for it out of your own pocket.
You know what? It's not something that has particularly appealed to me at the moment, but that may be more of a reflection of my own lack of detail when it comes to looking at my own health. But it's not something that's hugely appealed. I don't know. I think that's probably in my mind because I consider myself low risk. So at the moment, I think the downsides, the limitations of this test for me outweigh any potential gains or benefits. Now, look, that may change as the technology advances, as I get older and think about things and maybe change my view on this, but at the moment it's not something that hugely appeals personally. How about yourself?
I don't think so. I think you framed it nicely, that it depends on your personal position and outlook on life. I mean, no one knows if cancer's waiting around the corner, but I guess we're both relatively young and lucky to have good health at the moment. I think my answer is a no, but I'm certainly keen to keep my finger on this pulse, and will be avidly waiting in anticipation of when they publish the big study in the NHS and what future tests might come out from this.
Good stuff, Matt. Enjoyed that. As every week, I make a plea. Please like, please subscribe, please share with your friends. Matt reliably informs me that we are making a website, which was news to me, but that's quite exciting. So we'll share all of those details when available. Get in touch with us, drop us an email, send us a text. If you've got any topics you want us to cover, feel free to raise them, leave us a nice review, and we will hopefully see you next time.